life. So it's very, very important. Learn robotic surgery properly and then do the wonderful stuff that you guys can do. The case load you have, you cannot do that in the UK or Europe. So you guys can do wonderful stuff with the robot. So and I'm sure you will do it. Next, please. So this same thing, robotic instruments. So laparoscopic surgery, you place some ports. Robotic surgery, you send the same ports, and those are the ports are held by the robot, and that's the only difference. Next slide, please. So the robot will enable you to do complex cases in a minimally invasive manner. It is not different than laparoscopic surgery. So you should not compare laparoscopic versus robotic surgery. You should be able to do complex cases with a robot, which are otherwise extremely difficult. Next slide, please. Next slide, please. So again, all the advantages of keyhole surgery, like next slide, please. Like 3D view and endo-receipt instrument. So the instruments mimic the movement of the surgeon's hand. It's like having small hands inside the patient's body because it just move and circumduction and abduction flexion, all that. So it's like having a small hand in the patient's abdomen. Next slide, please. So these are a couple of my patients. So they are both my patients. On the right, one had a open liver resection, had no complication, went home day 7, day 8. On the left side, the patient also had a right hepatectomy. She went home day 4. The advantage is 3 days. So the patient after major liver resection in my hospital don't go to HDU anymore. They go to a surgical ward. But the open resection, they have to have an epidural and central line. We don't put that in the robotic cases. So they go to a normal ward and they go home a bit sooner. So there's a 3-day difference in discharge. Next slide, please. So this was a redo liver resection on the right side. So we had to make a very funny incision on the left side. Again, the patient with a right hepatectomy. So the difference is about like a few days if you do it properly. Next slide, please. So evidence is, there's a lot of evidence. Next slide, please. I'm not going to go into much detail. There is evidence that robotic is easier to learn as compared to laparoscopic surgery. If you will take 100 hours to learn laparoscopic surgery to the master level, for example, you will need 50 hours to learn robotic surgery at master level. So there is an advantage, and it is easier to learn, and that's the evidence. Next slide, please. And robotic liver resections. People have done robotic versus laparoscopic studies, and they have shown that robotic surgery is better with lower blood loss, and I agree with that, with a better dissection margin. And so pathologically, robotic surgery is better than laparoscopic. But from patient's point of view, they are both keyhole surgery, so there is no difference for that. Next slide, please. So again, difficult to reach area. For example, when you talk about the corded lobe, which is difficult to access laparoscopically, or ALPS procedure, the robot is extremely important because laparoscopically you can't, more difficult to struggle to do these cases. But robot can help you do these cases in a very effective manner. Next slide, please. If you look at the literature, so see the number of cases being published. These are the publications in the literature. So again, as you guys like know, PubMed is the place you go to whenever you're looking for an evidence. So this is a screenshot from PubMed, only taken day before I came to Pakistan. So search robotic and liver, we give you all the publications. So look at the graph going up. People are doing like lots of robotic liver resections, so we have to do it as well. Next slide, please. So these are hard to reach areas. For example, these one are easily accessible laparoscopically. But when you talk about these areas, so these areas are accessible laparoscopically quite easily. But these areas are difficult to reach, like segment 1, segment 7, 8, segment 2, 4A. And robotically, because they're endo-receipt, they can go over and above and down these instruments, and they can help you do those resections, especially parenchyma preservation. Next slide, please. So I have now done like quite a few cases. So I'll show you a few videos. Next slide, please. And I hope they run well. So I've done like this is my logbook. So I've done quite almost all types of cases. I started with cholecystectomies, then went on to do bile duct exploration, then redo cholecystectomy, hernias. But most of my work is major HPV. So right leg hepatectomies, RAMS procedures, Whipple's procedure. So tomorrow I'll be showing some video about a spin preserving disc appendectomy and a Whipple's procedure. That will be at 12 o'clock. So then we'll talk about the training program as well. Next slide, please. You could please play this video. So this is a patient who had a left hepatectomy and robotic hook is being used to open the pars placenta. There's a bit of a lag, but I'm sure. But yeah, we are dissecting the blood vessels, so dissecting the left hepatic artery. This is the edited video. So when you edit the video, you take away all the bleeding parts, so you have to make it look very beautiful. So the left hepatic artery being dissected, and then we sloop it with a vicryl tie. I use vicryl instead of the nylon ties because if you have to fire a stapler, or if you use a hemolock or something, or if you have to tie, the suture is already there. And if the suture is caught in the stapler or in the hemolock, then you can leave it behind, just cut it. But with the plastic or Teflon sloops, you have to take them out. So left hepatic artery has been dissected, and this is the left portal vein. We were lucky that this patient required a long left portal vein, so we dissected that. There's a lot of lag. So also it's a bit slow as well for some reason. Anyway, you get it anyway. So the left portal vein is now being slooped with the same vicryl tie. We cut it to 10 centimeter. So again, when you're doing the robotic surgery, you are away from the patient. So you're on the console, and the patient is on the table, and the robotic instrument are moving on it. So some people have a dissociation syndrome. They feel a bit scared that I'm not onto the patient, and they just feel very itchy, very jittery that why it's not happening. So you have to have excellent communication. As surgeons are not good in communicating. When we are operating, we say, give me the instrument. What instrument? There are about a million of them. Give me the scissors. What scissors? There are about 20 types of scissors on the tray. So you have to be, sorry. So we say we have a trial clamp, the left hepatic artery and the portal vein. Then we give ICG, and this is a line of demarcation. So that line of demarcation. ICG is indocyanine green. We give that to the patient after clamping the blood vessels to see, to differentiate between the viable and non-viable part of that organ. So we gave ICG, and that told us the line of transaction was there. And then we did the parenchyma transaction. There is, yes, please go ahead.
Just a quick question: is it SI or XI?
This is the XI. But I started on the SI. That's how I started. So this is an upgrade because our old one expired. So we're doing the parenchyma transaction with the monopolar scissors and the bipolar on the left hand. There is no ideal tool in the robotic platform so far to divide the parenchyma. That's why parenchyma does not look very neat when you are doing it most of the time. Next video, please. Next slide. So this is the short clip of the right hepatectomy. So we have done the cholecystectomy, I think, and now we are holding the cystic duct. This is the cystic duct stump. That's the common bile duct, and we are dissecting the hepatic artery over there. I try to go as high as possible on the arteries and go to the liver hilum because number one, you can do that with a robot. You can't do that with the laparoscopy most of the time. So I try to do right anterior posterior arteries and right anterior posterior portal veins separately. So this is the right procedures, and you can see the line of transaction. But this was the right hepatectomy, so we went on and did the right anterior as well. So again, dissect the vein. You have to be very careful because it is not a reliable tactile feedback. That means you do not know how hard you are pulling the tissue. It just feels the same. It's just like moving a crane. If you don't know how much weight the crane forklift is lifting, you just have to move that tiny nozzle. So you have to be careful. Next slide, please. Not to pull that tissue. So you have to work on your visual feedback, not a tactile feedback. You can only see with your eyes that how much tissue is being pressed by the robotic instruments or with the sutures. So that's the hepatic arteries are being dissected. You can now see this. I think we need to go to the next slide, please. Mobile later. So this is again a right hepatectomy. Yeah, play the video, please. So the previous one was on the S side, this is on the X side. So this was BMI was quite high. This patient had a BMI of 40, so weight was about 90 kilograms, so quite a big falciform. So we divided that. Then we did a cholecystectomy. This video was prepared by one of my registrars. So you need to know where to cut. Robot will not tell you where to cut. You need to know where to find the good place, the avascular planes. So that's what you need to know. So you need to be a surgeon and then need to have the minimally invasive principles embedded in you, and then you can use a robot. So cholecystectomy is done, and then we'll do the highlight dissection in a second. Anybody got any questions so far? Any comments?
Well, there will be time for that.
Yeah, okay.
Yeah.
I feel just I was sleeping or mesmerized, one or the other.
You use all arms, 3 instruments you use.
So instruments, yes. So I mostly use a hook on the right hand, bipolar on the left hand, but we also have a advanced bipolar instrument which are coming next. I'll show you those. So at the moment I'm still like using hook on the right hand and the bipolar on the left hand. And I have a third robotic instrument which is doing the retraction. So you see the liver is retracted upwards to the right shoulder, and that is being pushed in by a non-traumatic grasper. It's called carrier grasper. So the over there. So hilum is beautiful with the robot. You can't match that laparoscopically. It's just fantastic. The access you get, the view you get for the Pringles that I'll show you in the next video how we did the Pringles. So it's just beautiful. But the parenchyma is actually skilled. You still don't have a great instrument for the parenchyma. Sometimes, and the thing is, you don't want to make a liver dissection a two-consultant procedure. Because if you are doing the parenchyma with CUSA, another consultant goes to the patient. So when doing robotic surgery, you are away from the patient. So you need someone who can use the CUSA onto the patient. So registrars really struggle with it. So we've taken the artery. I think in this case we were trialing a stapler on the artery, but it didn't work, so we had to put it. So these are robotic bulldogs. Okay, as you saw, the robotic bulldogs, they have the endoris, so they can come in and they can bend down and then click. So very handy instruments, very, very nice. And this vein, as you can see, this is quite an annoying vein, goes to segment 4. To dissect the portal vein, you should always take, I'm sure you guys know this more than me. We take this vein, dissect it and use it, and use a robotic bulldog to secure the vein, and then have a long length of the portal vein and the right and the left. Again, I'd like to go quite high up into the hilum. This patient had the right anterior portal vein coming from the left, so we did not want to take, so we only want to take the right posterior portal vein. That's what we did in this case.
How are we keeping the retraction of the liver?
So retraction is being kept by a carrier, which is the third robotic arm, and it is keeping the liver up all the time. That's why it's giving me a stable retraction and stable view. Then this is the dropping probe we're talking about. This is an ultrasound probe that we are using. We drop it in from a assistant port, and then the surgeon holds it, and then we scan the liver in real time. That tells us about, and also to the doctor, tells us about the vascular status, and the vessels are all intact with the future liver remnant, and if we are the right plane. So then we do this demarcation, and then so this is called synchrocele. I think sorry, there's a bit of a that is a head gas design. So this is a synchrocele. This is an advanced bipolar instrument, and this instrument just so this instrument helps us do the dissection. So we can look at this vein. So and then you can see I used my assistant to use CUSA for some time, but he didn't do a good job. So we I just carried on with the synchrocele and the monopolar and bipolar. And then we kept going with the transaction line over there. All the pedicles, you can see some hemologs for use, and the right hepatic vein was then divided into the stapler. They are not synced. Okay, could you please move, go to the next video? Okay, so this was a redo liver dissection. This patient had a dissection of segment 6-7 lesion. And please play it. And this will tell you the real advantage of doing robotic. And keep an eye on the hook, the way it bends and the way it helps you go to the hard to reach areas over and above. So this patient had a previously liver resection and then had a recurrence at the resection site because the previous resection was R1. Then came to me and I offered liver removal. You can see the way hook bends over there, and this instrument stands at this angle. And this you can't get in laparoscopic inventory. So we do the liver, so dissect the liver from where the dissection was done previously.
Previous open surgery.
Yes. So previously when I started, I was being a bit more selective to offer robotic surgery to patients who are suitable. But now I only have robotic list. So everybody, I offer them robotic resection, even if they, so one patient that I think maybe next or not, that patient had open surgery, then burst abdomen, and then incision hernia, and then repaired with a mesh. And I said, well, first you have to lose, let's try with the varus on the left side and do robotic. And we were able to manage that. So you should not deny these patients the opportunity of robotic surgery without putting in the scope.
For demarcation, it is only ICT which matters, or we have different options.
So we can do either or, but ICG is so first of all it's visual, because in this case you saw there was a line of transaction, and then you can give ICG and then you can do Doppler as well. So just like to be short, 3 times. And you can see that we're doing the Pringles in this case. So I open the pass list on the left side, and then from the right side we'll insert. I did not want to edit this part, but wanted you guys to see how Pringles is done. There's no tactile feedback, so you have to be quite careful. You don't want to rip tissue apart, because you're going behind the portal vein blindly over there. So you're going blind through the foramen influence of portal vein. So you don't want to cause any damage. You can see the IBC is quite visible over there. So and when we have no tactile feedback, you don't want to rip the tissues apart. The bleeding can be catastrophic. So initially I tried, and I thought this because the window was not complete. So we do the Pringles using the nylon tape, and we have the control outside. So we bring the tape out, go around the hepatic pedicle. So this is the unedited part of the video. Go around the hepatic pedicle. Then we use an 18 French tube drain. First of all, we mark the middle of this tape, because when doing laparoscopy, you don't know where the middle of the tape will come. So you will see there will be a purple part over there. This comes, and so this will go behind the portal pedicle. So then you bring both ends of the tape inside, and then the assistant puts a snugger or a wire like this, and then through a tube drain pulls the both ends of the nylon tape out through the port, and then that can be used for Pringles when required. I normally don't prefer to use some Pringles, always apply it, but try not to use it. That's how I was trained.
सर डॉक्टर जी बात अभी तक ना मुझे रोबोट की फीलिंग नहीं आई, ऐसे लग रहा है जैसे लेप्रोस्कोपिक फीलिंग है
जी
वो आप भी नजर आए मुझे ऐसे ऐसे करते
That's outside.
I think लैग की वजह से वो जो एक प्रिसिजन की फीलिंग आती है
जी, it's very very precise, sir. Very delicate, sir.
एग्जैक्टली वीडियो की किसी वजह से आई थिंक ब्रेक हो रही है
This is good video.
बस वीडियो बनाई हुई थी इन्होंने ना थोड़ी सी ना गेयर भी लगाया हुआ था वीडियो में ऐसे लग रहा था कि फिर जबरदस्त तेजी से कर रहे हैं सर वीडियो डिस्प्ले
नहीं वो फास्ट सर एडिटर में है ये ऑप्शन आप फास्ट करें
2 hours की तो नहीं दिखाई जा सकती ना
This is an honest video. The real time. So what I do, like when you are, so I saw the other colleagues showing us the video. Any solid tissue resection, whenever you're using monopolar or bipolar suture, if you put some saline onto it and keep the parenchyma moist, that's when the dissection will be more of a hydrodissection with the burning water, and that gives you quite a neat transaction line. So in this patient, we then dissected the pedicle to segment 6, and then used the Himalox to control the pedicle segment 6. Again, I use the vital ties to control the pedicle. It's a bit cheap and it's a little bit more flexible. So in this case, we are using the laparoscopic pneumologs. So robotic instruments are quite expensive. So when you talk about intuitive instruments, so one instrument costs about 1,700 pounds, and it has 10 lives. You can only use an instrument 10 times, so 170 pounds per use. And again, when using the hemologs, so one instrument can be used 100 times for the 100 hemologs, and they again 1,700 pounds. So one hemolog application is about 17 pounds. So sometimes we just have to be careful not to use too many of these things. If we do that in the UK as well, we have to save money to be able to show that the program is viable.
This is the Da Vinci.
This is the Da Vinci XI, yeah. But as I was saying earlier, a robot is a tool. You can have a Suzuki or a BMW. It will take you from A to B. Suzuki may not have the power steering, may not have, or may have it, but it will take you from point A to B. You have to start somewhere. And the robot that you have, CMR, is perfectly capable of doing all these cases. We were talking about that, so when the CMR was being developed, they invited me and I spent 2 days on a cadaver. Go to the next slide, please. I spent 2 days on a cadaver and did resection of the liver and pancreas, and even they acknowledge it is not ready for a major liver pancreatic resection. That was 2018, 2019. But they have now come further from that point of view. In the UK, there are 170 robotic systems installed all over the country. 160 of them are intuitive. There are only 10 CMR in the UK. So they will, and the robot has a life of 10 to 15 years. So CMR will struggle to get into UK market for the next 10 years. Their market is Asia, India, Pakistan, Bangladesh, and this country. So they have to develop the robot as well. So this is their first generation. Intuitive first generation was year 1999. Now they are on their 4th generation. This is the CMR first generation 22 years later. So they will develop second generation, third and fourth generation, just like iPhone models. They will keep on bringing new instruments, but they need help. And the help is through the data that they collect by using. So whenever you are using the CMR, it goes into recoverable fault, non-recoverable fault. They take the videos, the data that you were showing earlier is very useful for you guys. But for them, this data is worth millions, because that data is being used to make their next robot. So they are in a very happy position that they are giving you the robot, you are using it, and they are learning from you and also charging you. But you have to go somewhere. So this is the start, and that's what you should do.
Ready for market? Yes. Will you upgrade the next model for free?
Just last slide.
Only
Since there is
we did discuss this CMR में हमें काफी problems आ रही थी because हम hybrid में काफी जा रहे थे laparoscopy कर रहे थे, तो उनकी instrumentations जो है ना वो भी अभी develop, उनकी 2-4 ही उन्होंने develop की हुई है और
So are you charging for the development?
No, we are not charging for the development. Now that we are aware of it, we may charge them now.
I think it's very pleasing for us to know that one of our countrymen is doing such a great job and is the lead over there. It's a matter of pride. If there are any questions from the audience here, they can ask a question. First, they should introduce themselves. And if not, so I'll start with the first question. As you said that you should start with the easy cases, and we know that in the laparoscopic liver surgery experience, that they have devised certain scores, and in which they assess the complexity of that liver resection, and they usually go for the left side first. So are there any such scores available in the robotic liver dissections, or you can start with anything?
Well, you should start with anything. You should start with simple cases. So it's the same score applies. So the score that you're telling about, they are in minimally invasive liver surgery. It's not laparoscopic or robotic, because both laparoscopic and robotic are minimally invasive. As the word suggests, it is a minimally invasive surgery, no matter how you do it. So people do endoscopic, endorectal surgery. So that's also minimally invasive rectal surgery. And people do upper GI endoscopy and then resect the tumor with the EMR and all those techniques. That's again minimally invasive surgery. People do interventional radiology and then ablate the tumor. That's also minimally invasive. So all these techniques are minimally invasive. I think the same score should apply to the robotic one.
My second question would be regarding the timing of ICG administration. And secondarily, if you can just brief our audience about the Firefly mode or how do you change the cameras?
Yeah. So ICT is given in real time. So when we're doing the so ICT is indocyanine green, it goes into the body and then binds with the cells and then concentrates into the tumor tissue, and then it has arterial and venous phase, and it's washed out very quickly. But remains into the liver cells and for about 6 hours, and the liver tumors for about 48 hours. So when we are doing the resection for colorectal liver metastasis, we give them ICT 24 hours beforehand. When we are looking for the tissue viability, then we give ICT, and within 45 seconds it is into the circulation. Then you can see the liver, which is the viable part of the.
And the mode, you change the mode of...
So it's just a simple button onto the robotic console. You just press. It's called Firefly. It's a different mode onto the camera. You just press the button and it shows you the viability of the tissue.
Are all the robots ICG compatible?
So the fourth generation have ICT, but the older ones,
CMR ka we don't know.
CMR, they are bringing the ICT, but this is their first generation. So they are learning from you guys, and they are developing the robot. So you will help them bring the ICT.
Can you elaborate on what is ICT, because it's very new for us?
ICT is just
It's a chemical.
it is just an injection. It's an indocyanine green. It's just an injection.
Reflecting.
Yeah, you just indocyanine green. And in gynae surgery, they inject in the lymphatics, and that's what helps them to. They map the lymphatic drainage, and just like sentinel lymph node biopsy. So just like that, you give the injection in real time.
Used in partial spectrum as well.
You have
Yeah.
a question, sir? Please introduce yourself.
Enjoyed hearing your talk. It was good to see those livers, which are colorectal liver metastasis, because in Pakistan, since I've come to Pakistan, my practice has changed completely because they're mostly cirrhotic livers we operate on. Now, the major thing in liver resection is use of energy device. So what are the energy devices available for liver resection? Because CUSA is one of them, but then there's a range of energy devices which we all use for liver resection. So CMR, that's the robot we'll be using here. What are the options available for us for liver resection?
So when I started the program 2018, we did not have any energy device for the robotic liver with the SI system. We did not have advanced bipolar. But at that time, what we were using was assistant was using CUSA or harmonic from the system code, and the surgeon was just keeping the liver open. That's what the option was. And when the newest XI system came, then we have advanced bipolar. You cannot bend the ultrasonic wave. So harmony is quite straight. You cannot bend it. Robotically, they are developing a new system of bending the ultrasound, and they may bring in something new, but it's still not as good as the ultrasound that we have that we use laparoscopically. So I'm afraid we'll have to use CUSA laparoscopically or bipolar, or just the way we are doing the dissection with scissors, monopolar scissors with some saline dripping onto it to keep the parenchyma moist, and use some Pringles. And it does work most of the times. I did not have to convert any patient so far in the last 5 years for bleeding, not a single one. I had to convert because I could not get the negative margin. It was right on the IVC, so I had to lift it. I was not feeling comfortable at that stage. That's when I converted, when I could not do it. But I didn't have any conversion because of bleeding so far.
I think to start with the CM robot, probably the robot will be an assistant. And your assistants will actually be a surgeon cutting the liver with the CUSA. So that's how we are going to start.
We're nearly finished, so just keep going.
So it's going to be robotic assisted surgery rather than completely robotic.
So there's a new definition now coming. So
Robot assisted.
So there's a definition called purely robotic. Purely robotic is when you are doing the surgery purely robotic, and assistant is not using any next slide, please, not using any energy device at all. Because, and then second one is robot assisted. So Melissa Hogan, you may have. So some people in Chicago is quite. So I think you mentioned the first paper in the robotic VIPOS procedure done by PC Giuliani. He's in Chicago now, and he was doing purely robotic. But people he taught, they are now gone to robot assisted. But the difference is in the robot assisted, the assistant is also holding an energy device and doing some transactions from the outside, from laparoscopically. There's a third term which has recently come by Moguilan, and it's called roboscopic surgery. So roboscopic surgery is when we're doing half the surgery robotically and half laparoscopically. So one of our colleagues, he is in Italy now, he was in Southampton previously, he wanted to do laparoscopic ripples, but he had very high leak rates in the laparoscopic ripples. So what he has done now when he's gone to Italy, that he does a resection laparoscopically, if he's comfortable doing that. But to prevent the leaks, he then docks a robot and does a reconstruction robotically. And he calls it roboscopic surgery. So just like hand-assisted laparoscopic surgery and things like that. So these are new terminology coming.
I just want to know the artificial intelligence and the robot and the learning curve of the robot. Will it be possible in the future that you do like 100 robotic liver dissections and your machine is learning of the mistakes, and a time will come then it is just totally robotic without the surgeon. So it's just switching on the switch and then observing a robot doing everything on its own. I don't think it's a far-fetched fantasy. I personally believe it's going to happen one day, but just want your take on that.
So I also used to believe in it. I also used to believe that AI is going
हम
to.
क्लिनिकल असेसमेंट को नहीं कर सके, काउंटर टैकल डायग्नोसिस को नहीं कर सके कि डिफरेंशियल हमारे पास है तो हम इनकॉर्पोरेट कर दें सिम्टम और प्रोविजनल डायग्नोसिस आ रहा है, उसको हम टैकल नहीं कर सकते, तो कॉम्प्लेक्स सर्जिकल प्रोसीजर might not be possible.
So I also believe, sorry, let me finish. I also believe that one day robots will take over and do the surgery. And so they, but I'll give you two examples why I'm now moving away from that idea. In the US and UK, they have tried to triage the patients. It's health service, free health service for everyone. So they have tried to triage the patients via automated AI, who you call the person, and Siri or someone, Cortana or someone talks on the other side, you say about tummy pain, and they will ask you quick questions and they will prescribe you medicine. They have tried that in the UK and US and both failed miserably. I thought surgery probably some cases like hernia, cholecystectomy will be more reproducible. You can do that like joint replacement, things like that. But then outside our house, they were building a new road, and they had the cranes, they had the forklifts, they had everything. And they had to dig out the first 2 feet of the road. And the road is now stable. They scan the road, they know exactly where the pipes are underneath, and even then they still scan the roads, and then they do the digging by a person sitting on it. That was a perfect example that you can ask a robot to dig off that road and lay a new one, but it is still not deemed not safe. I do not think robotic surgery in the next 10 or 20 years will be automated at all. That's why they put an Ethernet cable into the robot, but they still don't keep it onto the open network because it is still liable to hacking, and they don't want to do that. So I don't think it will be automated in near future.
I think it will be a human resistance to do that, but otherwise it's all techniques, and the robot's learning curve to learn the techniques is much quicker than the humans. There are a lot of other examples of artificial intelligence where the robotic response or getting the data through the artificial intelligence is like 20,000 times faster than the capacity of the human astrocytes. So I think the humans will be a limitation, giving the robots all that to do, rather than the robots not advancing to that level.
So there was a very eminent scientist, Brian Cox in the UK, you may have heard of his name, and he's done some research on human reaction. He's a physicist, human reaction to any event. So when a pitcher playing a baseball, when he throws the ball, it is humanly not possible for the signals from the eyes to go to the brain and the person to reflect. So it is anticipation that the human brain develops with training and with observation and learning, and that anticipation helps the baseball player to hit the ball accurately and effectively. And the person who has better anticipation, he can have can be better. And that anticipation, they are trying to put emotion into the robot, but so far they haven't been able to.
Well, we have a talk on that tomorrow, AI in robotic
Yes.
surgery.
No, I
That's a
still want to
specific
contact
session.
that. I think it's not the emotions which make you capable to do a surgery. It's the skill. I mean, if you are doing a left lateral segmentectomy,
Yeah, there's not much.
there is no emotions and there is no extraordinary skills involved in doing
No,
that.
it's about the
If you just
anticipation.
set up the setting, the report is keep on cutting, wherever it bleeds, or a tissue of that density, it's going to clip and cut.
Yeah.
I think it's very much feasible, it's just down the corner. It's up to the humans whether they want to give the robots that kind of advancement.
It will definitely come, but not in the next.
एक छोटा सा
10
कमेंट आर्टिफिशियल इंटेलिजेंस को अगर आप सिंपली डिफाइन करें ना तो इट इज ट्रेनिंग द कंप्यूटर बेसिकली और उसके लिए प्रॉब्लम ये है कि द कंप्यूटर अनलाइक ह्यूमंस रिक्वायर्स अ लॉट ऑफ डेटा जब तक उसमें एक इंक्रीज नंबर ऑफ इन थाउजेंड्स एंड मिलियंस डेटा नहीं जाता तो वो प्रोग्राम नहीं कर सकता लेकिन जो CMR का जो सेटअप है कि जिसमें दे रिकॉर्ड एंड कलेक्ट ऑल दिस डेटा इट मे बी पॉसिबल बिकॉज इंट्यूटिव का इस तरह का सेंट्रल सिस्टम नहीं था
देखिए सर ये डेटा बेस्ड उनकी कोडिंग करना और उसके पीछे बैक एंड पे एल्गोरिदम्स डेवलप करना दैट इज व्हाट एक्चुअली आर्टिफिशियल इंटेलिजेंस इज वंस यू डू दैट बहुत सारी जगहों में उन्होंने कर ली हुई है देखिए आप बड़ी बड़ी फैक्ट्रीज हैं एब्सोल्युटली ऑटोमेटेड है आप एक चीज़ बनाने की फैक्ट्री देख लें मतलब चीज़ बनाना इतना सिंपल काम तो नहीं है कटिंग द लिवर इज मच ईजियर बट वो एक साइड से दूध डलता है एंड में पैकेट की फॉर्म में जबरदस्त चीज आपका स्लाइस और बिगर स्लाइस और छोटे चंक्स में पैकेट फॉर्म में लोड होता है ट्रक के ऊपर इफ दैट इज ऑल पॉसिबल कटिंग 200 grams of a liver how it's not
सर चीज डिस्कार्ड हो जानी है जीवन में डिस्कार्ड नहीं होना यहाँ प्रॉब्लम ये हैंड ओवर करने में एक बहुत बड़ी हेजिटेंसी
सर
है
हमें रिटायर हो लेना
academic discussion
जो पॉइंट वो उठा रहे हैं इधर से जवाब आ गया है कि कंप्यूटर नीड्स लॉट ऑफ डेटा
Yes.
और वैरायटी और
Yes.
जो हमारे एबनॉर्मेलिटीज टिश्यू एबनॉर्मेलिटीज अगर वो डेटा आ जाता है और वो उसको हम अलॉगरिथम में ले आते हैं तो इट इज़ क्वाइट पॉसिबल
And the diversity which a human anatomy has. I mean, all our lives we keep on operating, and every time we get a new thing, we say, "Oh, अच्छा ये पहले नहीं देखा." So I don't know, maybe.
बट इट विल
मैडम
टेक
मैं
टाइम
उसी साइंटिफिक पेपर्स की बेसिस पे आपको कह रहा हूँ कि ये जो डेटा को रिप्रोड्यूस करने की स्पीड है ना कंप्यूटर इज 20,000 टाइम्स फास्टर देन द ह्यूमंस इट ऑल डिपेंड्स कि डेटा इनपुट कितना बड़ा है उसकी बैक एंड पे कोडिंग कितनी अच्छी हुई है और एल्गोरिथम्स कितने अच्छे हैं बिकॉज कंप्यूटर तो इस तरह चलता है ना
उसमें 5 साल पहले एक सर अल्फ्रेड कुशेरी जिनको हम जानते ही हैं उनकी किताब की वजह
एनिमल्स
से,
पे ट्रायल कर देना
वो एक प्रोजेक्ट कर रहे थे एंड मैं उसके इनिशियल डिस्कशन में इन्वॉल्व भी हुआ था दैट वाज समवेयर इन बिटवीन दिस डिस्कशन उसमें यह था कि अब 3D इमेजिंग आ गई है तो यू कैन नो एग्जैक्टली व्हाट द लिवर लुक्स लाइक उसके बाद वही मॉडल की जो ऑपरेशन है आप प्रैक्टिस करेंगे ना सिमुलेटर में यू परफेक्ट द ऑपरेशन कहीं ब्लीडिंग हुई है यू स्टेप बैक एंड डू दैट अगेन और करके यू जस्ट प्रोग्राम इट टू द रोबोट और रोबोट उस ऑपरेशन को परफॉर्म कर देगा तो ये कॉन्सेप्ट 5 साल पहले हो रहा था डेवलप हो रहा था
Concept.
हाँ तो मतलब आई थिंक दिस विल probably develop. We don't know the
Come
future.
eventually.
लेकिन AI will be a huge role to play in future I believe.
I think definitely. Eventually.
Standardized होगा.
Eventually.
इसमें फैसल इसमें आपने जो बात की ना जो नमान ने अभी आंसर की है कि बेसिकली आर्टिफिशियल इंटेलिजेंस इज ऑल अबाउट ट्रेनिंग द रोबोट अब आप ट्रेन कर लें उसको जो है वो डाटा आप जो है वो चाहे 2000 का दे दें 1 लाख का दे दें लेकिन बात ये है कि एनालिसिस कम्स फ्रॉम सेल्फ और अ कंप्यूटर और आर्टिफिशियल इंटेलिजेंस इज नॉट सेल्फ अवेयर तो वो जो एक मतलब सेल्फ एनालिसिस है कि जो चीज़ सामने आ रही है उसको वो नहीं कर सकेगा तो काफ़ी हद तक हो सकता है लेकिन मतलब एब्सोल्युटली नहीं हो सकेगा
I will object to that.
Could we finish this, please? Excuse me. Could we just go to the last slide? I think that's the end of our presentation. Thank you very much for your attention.
मेरा एक सवाल
जी प्लीज
ये एक बड़ा एक कोड सा क्वेश्चन है
जी प्लीज गो
क्या हमारे पास कोई हेड टू हेड ट्रायल्स हैं रोबोटिक के और ओपन सर्जरी के जो प्रूव करते हो कि रोबोटिक सर्जरी इज जो है वो मतलब जो है वो सुपीरियर
सर
मतलब एक्सपीरियंस है बहुत से लोग हैं जो कर रहे हैं
सर देयर इज नो रैंडमाइज्ड कंट्रोल
हाँ
ट्रायल
लेकिन बात ये है कि मेरे पास अभी तक इंटुइटिव का अपना कोई ऐसा कोई रिसर्च पेपर नहीं है
जी
मतलब कंट्रोल ट्रायल हो जिसकी बेसिस पे वो कहें कि ये सुपीरियर है
So there is no RCD so far in liver pancreatic surgery. उन्होंने RCT किया था नेदरलैंड्स में between open and laparoscopic ripples. उन्होंने ये किया कि उन्होंने जो बंदे established थे open ripples के उनको लिया, and people who were doing laparoscopic ripples, they took them and then they standardized the technique and उनको सबको उनके 25 ripples उनके observe किए, then enrolled them onto the trial. Now the trial had to be stopped early because there was high mortality in the laparoscopic arm of the study. So there was the only trial that was attempted, not done, between laparoscopic and open ripples, but nothing in the robotic. There's one trial, I think it's going to be started, and we are starting that in Italy, hopefully in the next 2-3 years, that may enroll robotic versus open ripples as well. So this last slide, so robotic is here to stay, join or be left behind. In the UK, there are 170 systems. In India, I think there are about 400 plus systems already. In the US, there are about 700 systems installed of different types. So we need to start somewhere. So massive congratulations to you guys for bringing the robot here. So this is just the beginning of something really great. Robot does not do anything on its own. You need to know how to do the surgery, and you are in full control. Nobody flies a plane without full training. So please get the full training and do a safe surgery because it is for the patients. No patient must come to harm for our ambitious in the future. And major robotic sections are feasible. Thank you very much for this.
Is there any question from the audience?
Yes, one question. So you have been mentoring so many people and training so many people to become a final product of a trained robotic surgeon. So just one question, a humble question. Which of the surgeons turn out to be better robotic surgeons? The one who come from background of laparoscopy or the one who comes from the background of open surgery?
So there's a paper from Heidelberg. What they did was they did a randomized control trial. They recruited 3 different kinds of people. One were total novices, registrars who had some experience in laparoscopic and open surgery. Other one was accomplished laparoscopic surgeon. And the third one was accomplished open surgeons who don't do any laparoscopic or major section. For example, some like Marcus Buchla, he doesn't do any laparoscopic pericardial dissection at all. So they recruited about 60 people, and none of them had seen or done the robot before. And they put them onto the simulator, and they found that no one group was better than the other. Laparoscopic people did not do better than the open. Open did not do better than the laparoscopic. But the younger surgeons, they did better than both. So there is something in younger people that we are like, we have done maybe played more video games, maybe we are more economic. But I think what the difference that I see, so I've trained like lots of people. So the difference I see in people is the person who is enthusiastic, they really want to do it. So what they will do the simulation. If one person does 1 hour, they will do 2 hours. And if someone does 2 hours, they will do 3 hours. And then they are really keen, they observe, they really invest their time and life into that. They're really obsessed with it. And that's when they become better robotic surgeons. Otherwise, younger people, they do better. But older and more mature surgeons, laparoscopy open, nobody should stop. They all should try.
They have already done well in life.
They already done well, exactly.
They need to slow down.
Yes. Another question. We got 2 questions from the audience.
Sir, my name is Dr. Mohammed Asar. I'm a senior registrar in HPV and liver transplant. What's the role of robotic surgery in donor hepatectomy?
They are doing a lot of donor hepatectomies in India at the moment, I think. So a living donor program in the UK did not take off much. I think there were some problems. Faisal knows too well. But India is doing lots of donor hepatectomies. So and Mohammad Rela, I think he did the first one. Now they are doing a lot of donor hepatectomies. So that's definitely coming. But it's a 2-consultant procedure. One person on the console does the hilum and the vessels. Other person does the cruza onto the patient. So it is a 2-consultant procedure. It is a roboscopic surgery for donor hepatectomy, not purely robotic.
Yes, we do have a talk on that tomorrow. The last question, because we are running short of time, we are late in the schedule.
Assalamualaikum. My name is Dr. Roha, and I am a consultant cardiology surgeon at Peshawar. My question is that, as you said, there is no tactile feedback while doing the robotic surgery. And let's take an example of the Pringle maneuver which you were doing, and at the point you were going blindly behind the portal wing. So is there any alarm system which the robot will tell you that I am having an obstruction over here, or it is just going to clear that tissue?
It's going to tear. So if you are not careful, you can cause some serious damage because robotic instruments are strong enough and they will lift the patient off the table slightly. They are very strong instruments, and so you have to rely on your visual feedback. So after doing about 300 cases, I was a bit more confident, and I said, yeah, well, so I was doing end-to-end tracheostomy, and I was using robotic stapler. So everything that you do should be within your field of view. If you're not able to see something, you don't know how strongly that is causing damage to the tissue. So one blade of the stapler was outside my view, and I went through and through the bulb. And that was after doing so many cases. So it is the visual feedback, or once you have the visual feedback, there are visual cues that you develop with time, and you don't even have to actively learn them. They will come with a simulation and with some training. And so I wanted to discuss it because the Pringles when I was doing it. So I tried the first time and then I withdrew. Because when I was pulling the tape first time, I saw slight movement onto the tissue with the grasper. So that was a visual feedback. I did not feel anything in my hand. So I withdrew, I gave up and then tried again. And second time it came out smoothly. So you have to rely on your visual feedback, not tactile feedback. But it is all learnable.
Thank you very much.
My pleasure.
Thank you very much. Now we'll be moving to the second talk of this session, and that is the presenter will be Professor Arsalan Khan. He is a professor of surgery at SIUT Karachi, and he has a special interest in HPV and liver transplant surgery. And he is currently heading the general surgery team at SIUT, and he has played a vital role in establishing the robotic surgery center over there. So amongst his academic interests is imparting verifiable surgical training to the trainees. And today the talk alludes to the dynamics of robotic surgical learning curve with reference to his teams and their experience. And Dr. Sanan, can you hear us?